scientist of the World Health Organization, who will be leading a panel discussion in collaboration with the world's experts on what we've learned about COVID-19 transmission. And before we get started, I want to remind the network that we do have Spanish and French interpretation services available. So you'll actually be able to follow this conversation through an interpreter if desired. And additionally, for the question and answer portion of this session today, you will be able to submit your questions in Spanish or French, and the interpreters will then interpret. You will submit your question to us in English. And so for those of you who are new to this feature, you can look to the bottom of your Zoom screen and click on the interpretation icon. It's a globe-shaped icon. And when you click on the interpretation icon, you will see the options for either Spanish or French. And you'll have the option, when you click on that, to hear only the interpreter if you wish, or you can continue to hear the English in the background softly in addition to the interpreter. And we've had over 1,000 registrants for today's session, and we're grateful for the time you've taken out of your busy schedules to be with us today. The goal is for this webinar to be as interactive as possible, so we are welcoming your questions as we go, and request that you send them through the Q&A box at the bottom of your screen. And I will be assisting and handling your live questions in collaboration with Dr. Sanjeev Arora. Sanjeev?
Hello, my name is Sanjeev Arora, and I'm a gastroenterologist by profession, and I serve as the director of the ECHO Institute. We have started this global series for two primary purposes. One is to disseminate science-based knowledge all over the world. And welcome to all of you who have joined. And thank you to Dr. Swaminathan for accepting this challenge to coordinate this activity. And the second, we all know, the second goal is that we all know this is a global pandemic. Most of the responses in the world right now are national responses. So the purpose of this global series is to exchange ideas amongst experts from different parts of the world and have all of you listen to that exchange of how they can exchange some of their ideas, their wisdom, success stories, challenges with each other to see how we can help each other. So thank you all for coming.
All right, thank you, Sanjeev. And let's continue with a round of introductions. I want to turn your attention to the chat box, because as we're doing introductions, you will see the full bios included in the chat box that you can review. And let's begin with our moderator for today's session, Dr. Soumya Swaminathan.
Thank you, Matt, and greetings to everyone who's watching. My name is Soumya Swaminathan. I'm a pediatrician from India. I've spent most of my life working on tuberculosis and HIV research, and I was the head of the Indian Council of Medical Research before I moved to the WHO in end of 2017. Currently, I'm the chief scientist. This is a new position that was created in March of 2019 with the new science division. So, and I've been heading that. Thank you.
Thank you, Dr. Swaminathan. And then for our panelists today, let's start with Dr. Jay Butler, if you can introduce yourself.
Hello, everyone. My name is Jay Butler. I'm Deputy Director for Infectious Diseases at the Centers for Disease Control and Prevention, or CDC, in Atlanta. I'm a MedPeds trained infectious diseases physician. Have been at CDC on and off for a number of years, but also have worked in public health at the state level and also with a tribal organization.
Great, thank you, Dr. Butler. And how about Dr. Marian Koopmans?
Yes, hello there. I'm Marian Koopmans. I'm the head of the virology department, viroscience department of Erasmus Medical Center. I am a veterinarian by training, but have spent my life wandering through public health research, sometime at CDC, sometime in India, and now as director of WHO Collaborating Center, and also very much involved in One Health studies.
Outstanding, thank you. And how about Dr. Carla Suarez-Weiser?
Hello, everyone. Good evening, afternoon, and good morning. My name is Carla Soares Wise. I'm a psychiatrist originally from Brazil, but I've been working evidence-based medicine for the past 25 years, and I currently am the editor-in-chief of the Cochrane Collaboration. It's a pleasure to be here.
Thank you. And Dr. Anne von Gottberg?
Good morning, good afternoon, and good evening, everyone. I'm Anne van Gottberg. I work here in Johannesburg in South Africa at the National Institute for Communicable Diseases. I'm a clinical microbiologist and lead the laboratory at the NICD doing diagnosis for SARS-CoV-2 and have been integrally involved in our national response to the pandemic. Over.
Okay, all right. Well, thank you, all of you, for joining us today, and sharing your expertise. Before we begin, we do have some housekeeping items I would like to address, and I will ask if we can pull up the slide with housekeeping items. Today's session will be recorded, and the video links and presentation slides from each of these sessions can be accessed on our webpage. So please look within the next 48 hours. You'll see these presentations posted on the website, and you'll see a link in the chat with that information. Please note that all participants for this session will be in listen-only mode. We did receive numerous questions, over 100 questions through the registration, and we also anticipate getting many live questions as we go. We've already started getting some, and thank you very much. So we apologize in advance that we likely won't get to all of those questions, but we'll do our best to get through as many as we can. And if you would like to submit a question for today's session, I alluded to this earlier, but at the bottom of your screen, again, you'll see a chat box and a Q&A box. You want to put your questions in the Q&A box. And you'll notice that after you submit them, they'll disappear. That's because we're transcribing them to a live document to help us navigate the questions. Please also keep your eye on the chat box as we go, because you will see a number of resource links posted in the chat box that will be posted by our ECHO digital librarian and other ECHO staff. And we do also ask that you please refrain from answering questions that you see in the Q&A box. Thank you. And please, at the end of today's session, also look to the chat box, because you will see a link for a survey that you can complete to obtain your CME and CEU credit. That will also allow you an opportunity to provide feedback for today's session, and we would appreciate your feedback as well. We will be kicking off this session today with a high-level update from Dr. Swaminathan, and then we'll have a few minutes for questions before we then begin with our panelist presentations. And again, as the panelists are presenting their updates about COVID-19 transmission, please keep sending your questions through the Q&A box, because we have built in a lot of interactive time at the end to handle as many questions as possible. And without further ado, Dr. Swaminathan, over to you.
Thank you so much, Matt. And what I'd like to do is to really do a very quick update. Cannot cover all topics because that would just be too much. But before I do that, I would like to dedicate this session and pay tribute to a very close friend and from my medical school days, who unfortunately passed away due to COVID complications just a week ago. And his name is Dr. Venu Ganapathy. I think all of us have been touched by COVID. I think we've all lost people that we know, close family, friends. And so while sometimes when you look at the numbers, you know, these are just numbers. And when they get into the millions, and, you know, it's every single death then comes back to you when it is somebody that you have known. Next slide, please. Just quickly going through the fact that I do not have any financial disclosures. And the next one is really the objectives are to discuss what is currently known about the transmission of COVID-19. So that's the focus for today. Next. But I will quickly run through the global epidemiological situation with the latest data, point you to the WHO guidance and resources that we have on our website, very high level key messages on transmission and how to prevent transmission of COVID-19, because our panelists are going to go into much more detail on this topic. And then to finish up with a word on diagnostics. If you go to the next slide, we're going to see a global overview of where we stand as of today. But this slide is actually showing COVID-19 cases per million population. If you look at absolute numbers, then it would order a little bit differently, with United States, India, and Brazil, followed by Russia and Peru. But if this is per million population, and the darker the color, obviously the most affected. The next slide, no, the previous one, is reflecting the same thing, but in a slightly different way. You know, we have 6 WHO regions, and so each of these colors reflects the pattern. So you can see the changing epidemiology of the disease in different regions. In the last 24 hours, we've had almost 300,000 cases confirmed and about 6,000 new deaths. We had sort of plateaued at about 5,000 to 5,500 new deaths for several weeks in the past, but this has again started to rise. And as you know, we're very close to 30 million cases cumulative and close to 1 million deaths. Now, I must emphasize that these are known cases and known deaths. And we know that in the majority of countries, that the cases that are known are an underestimate by 5 to 10 to sometimes even 40 times in some countries, depending on the extent of testing. So the absolute number of cases of COVID-19 are much, much higher than the 30 million that we know of. And similarly, deaths are not accurately reported or counted in many countries, and therefore the 1 million or so deaths are that we know. And WHO does have definitions for how to classify deaths due to COVID. These are both confirmed and suspected cases. Now, if you look at the yellow on this graph, it's the region of the Americas, so that's North and South America, which over the last several months has been the area with the greatest burden of disease and the fastest growing cases. We then have the purple, which is a Southeast Asian region, contributed in a large part by India, again, growing rapidly over the last several weeks. And then you have the European region, which you can see has a biphasic curve, had a big peak in March and April, went down in June and July, and now the number of cases has started increasing again. The Eastern Mediterranean region, which is in green, has sort of kept steady, and a few countries in that region are the ones who've contributed cases, a lot of cases. And then you have the Western Pacific region, where you had the big initial outbreak in China, followed by minor clusters in many countries in the region, but really that's actually the smallest number if you look at it region-wise. The black line that runs across are the deaths, and again you can see the peak in April and then stabilized because the deaths have come down in terms of case fatality rate, but overall, as I said, 6,000 new deaths every day currently being reported. The next slide, basically, I just want to say a little bit about symptoms. We know that most people will experience mild or moderate symptoms, and 10 to 15% of cases will progress to severe disease, and about 5% will become critically ill. And typically you can see the time period for recovery ranges from 2 weeks for those who have mild disease to up to 6 weeks for those who have more severe illness. But we also know that symptoms can linger for weeks or months. And we're also learning now that even people who had initial mild illness continue to have some symptoms for a long period of time. Some of these are severe complications, chronic lung disease, neurological problems like strokes, and all mental health problems, which can actually become chronic disabilities, but we're still learning more about that. Next slide shows a recent phone survey that was done in the United States, basically just to show that when people who were called 14 to 21 days after the onset of symptoms, quite a significant proportion, about 50% or so, continued to report symptoms at that point, and you can see the list of symptoms listed there. Next. Now, there have been long-term health studies performed on other coronaviruses, and here are some references to show that with SARS-1, a study that followed survivors over 24 months showed that they had persistent and significant impairment of exercise capacity, particularly in health workers. And another study showed 40% of people who recovered from SARS still had chronic fatigue symptoms 3.5 years after being diagnosed. So we still have to do these long-term studies with SARS-CoV-2. The next slide actually demonstrates that the virus, we know now that this is a systemic illness. It is not a virus that's confined to the respiratory tract. We know that many body organs and systems can be affected: the heart, the lungs, the brain, and the nervous system, starting with anosmia, but we know thromboembolic events and cognitive impairments. Mental health is being increasingly reported in people who've come through an illness, and also this chronic fatigue and musculoskeletal symptoms. Then we have a number of risk factors for venous thromboembolism, which include comorbidities, age, male sex, obesity, ICU admission, and evidence of ongoing inflammation. And we're learning a lot also about the pathophysiology of this disease, and thereby learning to also manage it much better than we did at the beginning of the pandemic. Next. I just want to move on to telling you a little bit about the WHO resources. We'll talk a little bit in the panel about how evidence-based guidelines are done. As you know, we've been putting out our guidance right from the early part of January, as soon as we heard about and learned about this new virus, starting with SOPs on diagnostics and on testing. We publish a lot of documents, but we go through a systematic process of quality assurance, and we've set up those mechanisms to deal with an emergency situation when you need to be timely, but you also need to make sure that it's evidence-based and quality assured. So we have staff members who volunteered for this, plus a big network of external groups, including the Cochrane Collaboration and many others who've been helping us to do these rapid reviews and evidence updates. And currently we see that our documents are downloaded from 4 to 9 million times per month. This is a significant increase over what it was pre-pandemic. The next slide just shows you some of the resources we have and gives you the link to the page where you can go and find all our COVID-19 resources. And I would like to now just say a few words about transmission. So if we go to the next slide, this has been a high priority for WHO right from the beginning. And it was a research priority for us from the beginning. And it's also been something that we've constantly tried to keep on top of in terms of scientific evidence. We had a scientific brief that was published in April, and then it was updated in July. And currently we are working on updating it further with the studies that have been done between July and now. This is on the right-hand side, you see a picture of a document that was just uploaded earlier this week, which was basically a guidance for school-related public health measures in the context of COVID-19. This was done jointly with UNICEF and with UNESCO, basically highlighting the importance of thinking about children more holistically. Of course, infection is very important. What are the risks? And we know that children get less severe disease, but what's the extent of infection in children? Again, differentiating between younger children, primary school, and the older children, teenagers, etc. Transmission both to and from children. We're understanding more about this. There are more studies, but we still are waiting for more studies now that schools have opened in many countries. And so this document covers some of these most recent findings. Now the next slide basically tells you how we think about transmission, because transmission of this virus is how, it's what are the ways in which it can transmit, when it transmits during the course of the infection, and where, what are the settings in which transmission is most intense in terms of both the duration and intensity of exposure. Now, when we talk about what we know and what the current evidence supports is that majority of transmission is from symptomatic people via droplet transmission through direct contact. So being in close proximity to somebody who's infected and being exposed to the droplets that come out during talking, during singing, during shouting, laughing, and even normal breathing. We also know that it can be transmitted through fomites in the immediate environment. And we are aware of studies that have proven virus can be isolated, live virus can be isolated from air samples. Most of these studies have been done in hospital settings where there are a lot of infected people. It proves that the virus can exist in aerosol in the air, and that in hospital settings, this could become a risk. And that is why health workers really need to have good PPE, good protection. However, outside health settings, there still are not too many good studies showing the importance and the extent of aerosol transmission. There are some hints from epidemiological studies, from some descriptive studies of closed environments where there is crowding, like pubs and restaurants or other even office spaces where a lot of people are spending a lot of time together. There's poor or no ventilation. This could potentially occur. So it's very much a possibility, and we're yet to figure out. But what we can say with confidence is that most transmission currently is through droplets from infected people. When does it occur? We know now that people who shed virus can be asymptomatic, and people are most infectious a couple of days before they develop symptoms to about 3 to 5 days after they develop symptoms. So that's the period of most infectivity. We also know that people who are asymptomatic can also transmit infection. However, again, currently the knowledge base points to the fact that most people who transmit are either in the pre-symptomatic or early symptomatic phase. Where does it occur? Primarily among close contacts. And as I mentioned, transmission can be amplified in closed, crowded, and indoor settings. Now, the next slide basically talks about what can we do to prevent transmission. And I think everybody's familiar with the measures that we come about. There are one set of measures that governments and ministries, local administrations have to put in place, which is identifying cases, being able to test them as quickly as possible, being able to isolate them, as well as being able to track contacts and quarantine them for a period of 14 days, because that's the upper limit of the incubation period. And the others are measures that individuals need to do, like wearing fabric masks when you cannot maintain physical distancing, health workers sticking to IPC measures, hand hygiene, respiratory etiquette, avoiding crowded places, ensuring good ventilation, as well as cleaning and disinfection. And very importantly, trying to prevent or avoid amplification events. And the next slide again is just a pictorial representation of the measures, which can be quite, it's quite a nice pictorial of how people can protect themselves and others. Now, the next point is about diagnostic options. As you all are aware, the gold standard is the nucleic acid amplification test, or the RT-PCR, which is the reference method. It diagnoses active infection. It is much more sensitive because it's looking for the RNA of the virus. So it's more sensitive than culture, but does not equal infectivity. We know that RNA fragments can be found, can be detected in various specimens for a long period of time, sometimes for weeks and weeks. It doesn't mean that that individual is infectious. And we have to remember that. There's also limited access globally. At the beginning of the pandemic, there were only 2 labs in the whole of the African continent that were able to do this test. Today, all countries in Africa have at least 1 lab, but again, majority of countries have limited capacity for testing. And even in the high-income countries, we've seen that when the epidemic really grows, that they start running out of the capacity to do RT-PCR. So the antigen detection test is another way to diagnose active infection. It's simple to use. There are many now coming with the lateral flow format, paper-based, strip-based tests, which are very fast, 15 to 30 minutes, relatively inexpensive. People can even do it themselves. The saliva-based tests are in development. It picks up those who are most infectious. The sensitivity and specificity are lower than PCR, but the advantage is it picks up people who are infectious, and it's very fast, and you get results on the spot. Because in many countries, we've seen one of the problems with the RT-PCR test is it has to go away to a lab in a remote, in a different setting, and then the individual has to wait for the results, which ideally should come back within 24 hours, but we know that in many situations it doesn't come back for several days. And by that time, it's a bit late to even start doing the contact tracing. So there are advantages of having a rapid test, which would enable both the person to be taken care of clinically, but also contact tracing to be done. And then we have the antibody detection, which can be done either by regular ELISA tests in the lab, or you can also, there are also rapid diagnostic tests for antibodies. Antibodies start getting produced around the second week. And so the peak probably is around between the second and third week of illness. This is useful for epidemiological studies and surveys, and we can talk about that more later, not for acute patient management. The next slide basically tells you what I was just, shows you pictorially that the RDTs, antigen RDTs pick up, during the period when the person is most infectious. So just before and a couple of days after the development of symptoms. Whereas you can see that the PCR detection cutoff is much lower, and therefore it remains positive for much longer. And then the next slide is about the WHO procedure called the emergency use listing, which of course other regulatory authorities also have. We put out a call for expressions of interest for RT-PCR, for antibody, and for antigen detection tests. Currently, there are 4 antigen detection tests which are under evaluation, and we should have in a couple of weeks on our website the results. So this basically builds some confidence and allows countries to go ahead and buy the ones that are WHO approved, either through an emergency use listing or through a pre-qualification program that normally takes a little bit longer. So finally, I would like to conclude by saying that while we're going to talk today about what we know about transmission, there are still unanswered questions, and we need high quality interdisciplinary research. You need the biomedical engineers, the aerosol biologists and scientists, mechanical engineers, as well as virologists and epidemiologists to really have a better understanding about the how, the where, and the when of transmission. It's very important as we're going into the second phase of the pandemic that both governments and citizens have responsibilities and need to follow the public health measures that we know work while we wait for vaccines and other innovations in diagnostics and therapeutics. We will continue to update our guidance. We work with hundreds of global experts and advisory groups to update our recommendations based on the latest scientific knowledge. And of course, we are also playing a major role in facilitating and promoting, and in some cases, coordinating research in many different areas, including epidemiology, transmission, but also including therapeutics and vaccines, clinical research. I'm going to stop there, and perhaps then it's time to move on, unless you want to stop and take a few questions or clarifications at this point, Matt.
All right. Thank you so much, Dr. Swaminathan, for that presentation, sharing this summary of the evidence with us. We're already receiving numerous really excellent questions. I think to make sure we get to all of the panelist presentations, we'll do those after the panel presentations. But before we begin, I do want to announce that Dr. George Gao is on, and I want to ask Dr. Gao to introduce himself as well. Good afternoon.
Good afternoon and good evening here in China. This is George Gao. I'm the Director General of China CDC. And I'm also a virologist working on emerging viruses, including coronavirus.
All right. Thank you so much for joining us, Dr. Gao. Looking forward to your presentation as well. And back to you, Dr. Swaminathan, if you would like to lead us into the panelist presentations.
Nice to meet everybody here. Thank you. Over.
Thank you, Dr. Gao, for joining, and thanks to all the panelists for giving their time today. I'd like to now invite Dr. Jay Butler from the CDC to make his presentation. What we've tried to do is to have each of the panelists address a couple of key issues and questions, and then we will have enough time for discussion at the end. So over to you, Jay.
All right, thank you, Dr. Swaminathan, and I'm really excited to be here today. Determining and addressing the modes of transmission of SARS coronavirus 2 is crucial to prevention, and particularly during this time when effective vaccines are not widely available. Next slide, please. I have no disclosures. And the learning objective is I'm going to build on some of what Dr. Swaminathan has already said about the transmission of COVID-19. Next slide. So I'd like to set the stage for my comments as well as the discussion that will follow by outlining some of the challenges to understanding the transmission of SARS coronavirus 2. It's important to keep in mind that we're talking about a virus that we didn't know existed only a year ago. And in fact, it may not have even existed a year ago. So the amount of information that we've gathered and what we've learned over the past 9 to 10 months is really quite astounding. But let's start with the most unpleasant surprise that we received as we learned the epidemiology of COVID-19 and attempted to implement evidence-based and reasonable control recommendations. And that's the fact that persons who are asymptomatic can shed the virus in respiratory secretions. There's strong epidemiological evidence that transmission can occur from people who have not yet developed symptoms as long as 2 to 3 days prior to onset, and from those who are infected but never developed symptoms at all. The peak time of viral shedding and infectiousness for those who become ill appears to be right around the time of symptom onset and shortly thereafter. This is very different from what has been observed with the virus's closest cousin, the SARS coronavirus, where shedding appears to be greatest at the peak of symptomatology. While we don't know precisely what proportion of transmissions occur from asymptomatically infected persons, models conducted by our group at CDC and with academic partners suggest that as many as 1/2 of all transmissions may be from persons without symptoms. A second challenge is the detection of RNA in a wide variety of body fluids and from environmental specimens by a very highly sensitive PCR does not necessarily tell us everything we need to know about infectiousness. The PCR does not distinguish between shreds of RNA incapable of causing infection and intact infectious virions. And finally, the number of people who are infected by one infectious person can be highly variable. And this has led to the term super spreading events, a term that I first remember from investigation of SARS in 2003. And this is when a single infectious person infects a large number of others. An example of a super spreading event that occurred early in the pandemic in the US is a cluster of infections linked to an evening choir practice in Oregon. One choir member developed mild illness and attended the evening practice. Of 60 other persons at the practice, 32 developed COVID-19 confirmed by PCR, and 20 more developed symptoms of COVID-19 for an overall attack rate of 87%. 3 attendees were hospitalized and 2 died. While the high attack rate following an activity that we know can produce aerosolized respiratory secretions, suggestive of airborne transmission, it's important to keep in mind that the practice attendees were together, mixed, shared refreshments over a 2.5-hour period. Thus, a super spreading event like this can provide supporting evidence of airborne spread in some situations, but absent additional data, it does not prove any specific mode of transmission. Next slide, please. So to summarize the current view of transmission at CDC, taken together how current understanding of the epidemiology of SARS-CoV fits together, we believe that it spreads more efficiently than influenza, but not as efficiently as measles, a virus with strong evidence of airborne spread. The R0, that is the average number of persons infected by one infectious person for influenza, is generally estimated around 1.3, whereas the R0 for COVID-19 has a wide range of estimates, but mostly between 2 and 3.5. It is thought to spread mainly person to person through respiratory droplets produced when an infected person coughs, sneezes, talks, or sings. These droplets travel as ballistic projectiles that can wind up on the respiratory mucosa of people who are nearby. As I mentioned earlier, under certain conditions, particularly when aerosol-producing procedures are performed in healthcare settings, airborne spread is plausible. But the virus may spread in other ways as well, such as fomites, touching a surface or an object that has the virus on it, and then self-inoculating by touching the mouth, nose, or eyes. One piece of suggestive evidence, it was in a report in JAMA Ophthalmology this week from China, that found that persons who wear eyeglasses may be at lower risk of COVID-19, and the authors speculate that persons who wear glasses may be less likely to touch their eyes with contaminated hands. Next slide, please. For the sake of time, I'm not going to walk through this slide in detail, but in thinking about airborne transmission, it's particularly important to think through the classification scheme of airborne transmission. And this was a paradigm created by Don Milton, and it talks about how some infectious agents are obligate, that they're mainly transmitted or only transmitted by the aerosol route. Others have preferential transmission. Others are opportunistic, where airborne route is probably more common, but that sometimes the virus can become airborne, if you will, in droplet nuclei, and spread over longer distances. And an example would be the SARS outbreak that occurred in Hong Kong in the Amoy Gardens apartment complex in 2003. Next slide, please. So in summary, the risk of person-to-person transmission is complex, driven by a number of biological, behavioral, and environmental factors. In general, the risk is higher with exposure to a greater number of infectious persons, closer proximity of a susceptible person to an infectious person, the cumulative length of exposure during the infectious period, lack of protective measures such as face coverings or masks, and finally, environmental factors such as airflow and airflow characteristics. And then final slide, please. As Dr. Swaminathan mentioned, there are a number of critical unknowns for us in public health as we strive to develop sound, evidence-based guidelines for prevention. Some of those questions include determining what proportion of SARS-CoV infections are acquired by the various routes and from asymptomatic persons. What are the conditions that facilitate super spreading events? What is the infectious dose of SARS coronavirus 2? Is the disease severity influenced by inoculum size or by the route or site of inoculation? And finally, what role and by what mechanism do face masks play in preventing the spread of COVID-19 in the community? I look forward to the questions and as well as the presentations that will follow. It's great to be able to speak to you today.
Thank you so much, Dr. Butler, for that really very clear and comprehensive overview. I'm going to turn over to Dr. Gao now for his overview of the topic.
Hi, everyone. Can you hear me?
Yes, George, we can. Please.
Okay,
yeah,
great.
go ahead.
Yeah, it's great. Yeah, it's great to be here with everybody. Hi, Soumya. Thank you very much for inviting me to be here. So I was told what I should talk, 3 major questions. First, modes of transmission. The second, infectious dose for transmission. And 3, animal-human transmission, the interface. So I will start with the modes of transmission. So from the early stage of the understanding, when we encountered this virus and this outbreak in China, by the end of December and early January, Of course, any patients in December, it's retrospectively, we went back to see, what going on there. But, all those first groups of patients we identified as early January. But when we came back to see, we might have some pneumonia with unknown etiology, and if we found something. But from the very beginning, we know it is, maybe it's an animal spillover. When you look at what happened there, so all the patients, they have a close link with the seafood market. So it looks like there, I myself went there, I saw, a lot of wild animals there. So we thought it might be the another SARS case. Of course, later it confirmed, maybe the virus already there for a while. I mean, that's my current understanding. Let's wait and see. We need some more data, but from the very beginning. And then, of course, later we realize it's through the droplets. Of course, in my own opinion, droplets do not mean aerosol. Of course, someone would argue with me, maybe aerosol means droplets. In my opinion, droplets, they're different from aerosol. Let's leave this one, but it's airborne. And of course, direct contact. Jay mentioned about one of our prominent doctors who thought he caught the virus through his touch of his eye. So this is why he thought all the doctors and healthcare workers, they should wear the glasses. Of course, later, I think during in March or later February, we realized, you got a lot of virus in the stool. So that again, that's the virus you found in the digestive system. Again, we still don't know whether or not the virus would be transmitted through the droplets or direct contact into your respiratory system. Somehow, maybe they reach to your digestive system, but they, you got the virus from the stool, but maybe it's not transmitted by the digestive system. We still don't know how the virus would pass through your pH less than 2 of your stomach. So that's still an open question, in my opinion. There's no direct evidence. The COVID-19 virus would pass through your pH 2 stomach. Of course, I want to mention to you, we already have 5 waves in China. That's my own opinion. I'm not Director General for China CDC here. I am only a scientist. That's my own opinion. Why it's 5 waves. And also because of these 5 waves, we thought there might be possible food package transmission. Because let me put there why I think 5 waves. This is the first wave in Wuhan. And after Wuhan, you can see we have a lot of small waves here. When you see the waves, it means wave means you have a peak, you have a valley. Look at this is a peak, valley, and peak, valley, peak, valley. A small peak, valley, and again, peak. If you enlarge that part, the red one means imported cases. So obviously we got the Wuhan case down to 0. We on April 8th, we didn't have any more patients in Wuhan. Of course, in May, we had a few, less than 10, cases there. It's still, when we did the sequencing, it's still the local virus. But after that, we have nothing in Wuhan. Of course, we have a lot of imported cases. You look at the red one. Those are suppressed. They didn't got into the local transmission, community level. Here, all this blue one means with some small peak. It's the wave, I call this one the first wave, the northeastern provinces in China. They were there, in Jili and Heilongjiang provinces. And then you have Beijing, Xinfadi, and then you have Xinjiang, Urumqi, and Dalian. In total, we have 5. The blue one is a community level transmission in China. If you put it even larger, you can see small peaks, always here. I call it 5 waves. Why? Look at this phylogenetic trace. If you look at this is the Dalian virus. the virus isolated daily cases. And here you have this dark yellow and also the green one. Those two are the northeastern outbreak. I call it outbreak. This is the second wave, there. And then we have Xinfadi, Beijing cluster together, and Urumqi. All those viruses, they have special mutations. They are totally different. Of course, one of the Heilongjiang strain in April, the virus is from one guy with a symptomatic infection, a lady from America. We did a sequencing. Clearly, you can see the virus imported from USA. Look at this. And of course, at the moment, we have something in Rayleigh, in the border with Myanmar. This again, this is a special virus related to the India virus and the Myanmar virus. And so, anyways, this tells you, where is the transmission in China? Okay, infectious dose for transmission. We don't know for that. Of course, we don't know. And it's always, we got some seafood or food positive for the nucleic acid. We don't know whether or not you can get a live virus. We haven't isolated any viruses from the food package yet. We are working on it. Of course, we got the genes. Animal human transmission, maybe, in my opinion, from the very beginning, early January, February, I always thought the virus, came from somewhere. Either it's bats or a intermediate host. It's transmitted to human beings. Now, look at the, really good adaptation for human beings. Maybe the virus already, in the environment for a while. Maybe they dominate, the virus is in the state of dominancy somewhere. So we don't know yet. Of course, let's wait and see. Like Sumia said, we still read so many scientific questions remain. So, of course, you don't know origin of the virus and the intermediate host, whether or not you really have an intermediate host, like the flu, or like the HIV. Do you really know which one is the intermediate host? It's monkey. You never find a monkey virus so, closely related to HIV. HIV, they're different viruses. So anyway, that's my quick presentation. Let's have some open discussion. Thank you.
Thank you so much. Thank you, Dr. Gao. Thank you very much for that and all the details about the outbreaks in China. A lot to learn from those. I'm going to turn to Marion Koopmans now for her presentation. Marion?
Yes, I cannot share yet because the presentation by George is still on. George, you have to shut down your presentation.
George, could you stop sharing, please? Thank you. These are all the new tricks we have to learn now when we make presentations.
Okay, so I think we're starting to see a pattern here. We've all been asked to talk about transmission. So what I have jotted down is what I consider from the work done so far really key issues. First of all, of course, SARS-CoV has multiple transmission modes, but really pinpointing how they work and which are the contributing factors is hugely complex. We have an infected host, we have a recipient host, we have different modes of transmission, droplets, aerosols, there's discussions about definitions there, and a list of factors on the host side related to how does the virus behave in people with different prior health conditions, what is the relationship between severity of symptoms and ability to transmit, questions like that. Then there's questions at the receiving end where a lot, in addition to the personal factors, there is issues about the setting that matters, but also a person's behavior and maybe a person's frailty where people need more direct contact. There can be an animal component. We are seeing more and more reports of transmission back into pets and maybe farmed animals. and back. And finally, of course, there is an increasing question whether the now further diversification of the viruses may come into the picture, and whether there is maybe differences in transmissibility for the expanding virus cloud. Second, very observation that we have now seen quite frequently from outbreak investigations is not all that seems an outbreak is an outbreak. Here's one example from our own experience, where there was a church service that seemed to have triggered a big outbreak in a elderly care home with high attack rates and high mortality, and it was really attributed to the church service. But when we then did add genome sequencing, we saw a very different picture. We saw that, yes, in the nursing home, there were some clustered cases, but really the sequencing showed that there were also a lot of sporadic cases, that there was widespread circulation in the community. So the end conclusion of this investigation was the church service may have sparked a little bit, but really the virus had been walked into the facility already quite widely from community cases. Third point I would like to make is the issue with animals. George Gao just mentioned it, and I do think we have a concern there. So this is looking at transmission of SARS-CoV-2 back into mink, which happened quite extensively in our country, but also in Denmark and in the US and probably other places. And where we've seen that if you study that also genetically, you see that, that there are multiple introductions, in our case 5 different introductions, but then quite efficient onward transmission of the virus between mink farms. Here's human sequences, and all of these are different mink farms where we start to see mink farm specific sequence signatures that then are transmitted back into people in blue here. So we see human to animal to human transmission, and with that also changes in the genomes that is difficult to control and is a concern, and I think needs to be looked at globally. Then a little bit about the how do we learn to maybe be a bit smarter in testing to control or testing to cut transmission. And this is looking at the use of the utility of these different assays that are coming to the market, where here this is a distribution of the amounts of virus at the time of diagnosis in the people that we are testing. There's every lab can produce similar data, where you see there's a lot of people with low levels of virus, and there's some people with very high levels of virus. There's a lot of discussion also on social media about false positives, low positives, positives that cannot be replicated. That is very much in this lower end. So by just setting a cutoff, you could get rid of those and already cut down on the amount of people to do contact tracing. This is when you add in the data from what we now know from specifications of different antigen tests. So as you can see, they differ a bit in how sensitive they are, or how much virus they need to be positive. And depending on where they sit, you can decide whether or not to use them. But then the key question, of course, is who of these people will go on to transmit or has most capacity to transmit the infection. So if you then bring into the equation where we can culture virus from respiratory samples from 2 different studies, you can see from this image that maybe these two antigen tests would actually pick up, while they're not so sensitive, but would still pick up everyone that is most capable of transmitting. So that would be smart testing to apply them. So those are my key points that I just want to share here.
Thank you, Marian. You've given us quite a lot of food for thought and also showed us the importance of using genetic sequence data to answer some of the questions that we have about transmission. So I would like to go now to Anne von Gottberg for her views sitting in South Africa.
Thank you, and thank you for this opportunity to join this conversation. I have nothing to disclose, and I'll be talking about transmission specifically from a South African perspective. And in South Africa, here on the left-hand side, you'll see our epidemic curve. Our first case was identified in 5th of March, and we had a very extensive and restrictive lockdown by the 26th of March. And you'll see that the number of cases were quite few at that stage. But then slowly the lockdowns and restrictions were lifted in our country, and we had the highest number of cases coming up in July. And if you notice carefully, you'll see that the numbers of cases have reduced, and ongoing now we're seeing reductions in cases. So overall, we've had 650,000 cases cumulatively identified in South Africa, and approximately 4 million tests done nationally in all the provinces in our country. If you look very carefully, these are the incidence weekly incidence risks for provinces, and you'll see that the shape is different for the different provinces and different peaks at different times. However, almost all provinces have reduced weekly incidence risks to less than 50 per 100,000 in these last few weeks. And so lockdown measures in South Africa clearly were effective to reduce transmission. And not only did they reduce transmission of SARS-CoV-2, they also reduced transmission of other respiratory viruses and respiratory bacteria. However, we also know that physical distancing and other non-pharmaceutical interventions were really hard in many communities in our country. So what we found is that there's been ongoing and undetected transmission if we look at seroprevalence studies. So now in different laboratories throughout the country by different groups using lab-based serological assays, both commercial and in-house assays, have shown that we have quite high seroprevalence, especially in densely populated communities in our cities, and up to 50% seroconversion has already been documented by different people. And so that does tell us that in part, some of these reductions that we are seeing may be attributed to some version of population immunity, and that we've been under-detecting the transmission that's been happening in the country. Although we are very grateful that hospital admissions and deaths were lower than expected in our country, we're very aware that these number of cases and what might happen later may change. And so to avoid any resurgence, we are obviously continuing very, very emphatically to recommend masks and physical distancing. And related to the story of airborne spread, that's exactly what would still be important. So that very question was raised by our government and our Minister of Health, and the South African Ministerial Advisory Committee then convened a technical working group. And this included, and we have these experts in South Africa, experts who really knew about tuberculosis airborne transmission. And in essence, their summary was that there are no absolutes, and that in fact most likely spectrums of transmission in SARS-CoV-2 are quite wide and variable. And that there's also a continuum of these droplet size. It's not the one or the other, it's not only small and it's not only big. And that we have to very carefully consider experimental results before we put them into real life settings. And we really need to consider both the expiratory event, whether they're coughing, singing, shouting, and what the temperature and humidity is in the air at that time. But most pragmatic and most importantly, we need to talk about closed spaces, very crowded spaces, and these have all been mentioned by the talkers prior to me, as well as close contact in those crowded spaces and prolonged contact. So the relative contribution of whether droplet and airborne, what is the quantitative relative contribution? I don't think we know yet, but we are clearly understanding that short-range airborne transmission, opportunistic transmission, airborne transmission is important. And our recommendations in healthcare are to improve compliance and quality of PPE and IPC. In the community, it's the emphasis of proper use of cloth masks, so over the nose and the mouth, and to maintain social distancing. But also very importantly, look at unusual circumstances like our commuter transport minibus taxis, which are filling to 100% at the moment, and see these as challenges that we need to address. We also know that overcrowded prisons will be a problem and are a problem. Places of worship where people will congregate in small spaces, but many people, bars and gyms. And I think the emphasis here has been throughout in South Africa is we need to improve adequate ventilation in these scenarios. And often it's as simple as saying to open the windows or to have the gatherings happen outside. So in South Africa, we're trying to answer some of these questions. Many collaborators and many researchers are doing this. One study that we're involved with is a household transmission study, both in a peri-urban and a rural setting, where approximately 100 households, almost 500 participants in each of these settings have been enrolled. And we're already seeing that we're seeing an unexpected prevalence of positivity of PCR on nasal swabs. A very intensive follow-up in the study for up to 6 months, and up to 5% have already been infected or are infected and PCR positive. And seroprevalence is also differential but high in this setting. And we're hoping that these studies and other studies will answer some of these questions going forward. And I'd like to thank you for your attention and my colleagues in South Africa for their collaboration. Thank you.
Thank you, Anne. And that's a lovely image that you had on your last slide, the coronavirus like a flower. Yeah, we need something to brighten up our days as well. And thank you for touching on the very unique situation, but I think it applies to other settings like South Africa, where you have these overcrowded urban settlements. I know several sero-epidemiological studies from India showing very similar to what you just described, anywhere from 30 to 50% seropositivity amongst slum dwellers, people who are living in these overcrowded settings with relatively lower clinical presentation. So a lot of scientific questions there, and I'm glad that you're doing these cohort and household transmission studies to try and answer some of these. We need more of those in different settings. And so now we go to our final speaker in the panel, Carla Suarez, who will be a little bit different. She's going to talk to us about methodology and how evidence is reviewed and guidelines prepared. Carla? Carla, can you unmute yourself?
Yes. Hello. Hi. Thank you very much. Thank you for these wonderful presentations. I mean, it's very interesting to sit here and listen to all of us and how much work we've all been putting to try to, for a common cause. What I'd like to talk to you briefly today is how in Cochrane we work to produce the evidence. I have no financial disclosure, except that I'm a full-time employee of Cochrane. And my view here is much more of the evidence in the public health measures to reduce transmission. So Cochrane is an international organization, not-for-profit organization. And the mission of Cochrane is to produce systematic reviews, high-quality systematic reviews to inform evidence-based decision-making. So this crisis, we've really made an effort to work together with our global network of experts, both content experts and methodologists, and create an environment, work with our partners and support developments in such as the World Health Organization to produce the systematic reviews. How do we do that? The first step for us is to write a protocol that is then published, that establishes the relevant question, what are the population that we want to discuss, and what are the methods and standards that we'll be using. But another important part of this process is actually to critically appraise all the included studies and summarize them in meta-analysis or in statistical analysis when appropriate. We're also very strict on conflict of interest, especially financial conflict of interest. So all of our reviewers have to, cannot have a financial conflict of interest. And another thing that we've put together in order to respond to the needs related to the COVID pandemic was to speed up our own editorial process. So you see some examples, but we knew that the evidence were accumulated. There was a lot of research being done, so that we needed to really create a mechanism that we have a proper quality assurance, that we identify the methods, that we grade the evidence, identify the potential bias of the studies, but we also keep these reviews up to date as new evidence becomes available. So as you probably know, there are thousands of, for example, randomized trials being published, at the moment being conducted, but at the moment we have 10 or 15% of them that are actually published. So this information will continue to grow. And the point that we have is that you have to have a proper method and a standard to summarize and provide you with the best evidence that you can use for decision making. Some of the examples of the reviews that we've published in the past 2 months are public measures to reduce transmission, such as universal screening, the digital contact tracing, quarantine, and travel bans. But we also published reviews on diagnostic tests, antibody tests, and rapid reviews. We published a review on hand cleaning using ash instead of soap, because we realized that in certain settings this would be important. And we published another review that it's of qualitative evidence, looking at barriers and facilitators to healthcare workers to adhere to infection prevention and control. So these are some of the examples. The Cochrane Library has all the reviews that we've published. But if we think about the public health measures, and just to give you a flavor of the last reviews that were actually published this week, so universal screening, most of the studies at the moment are one-time screening of health population, and they are likely to miss people who are infected. The quarantine review has initially published in April and has been updated this week, and reflecting the results of 51 studies. And actually, quarantine in combination with other public health measures can help slow the spread of COVID. The same applies for travel bans, that it has a positive impact on infectious disease. And the digital contact tracing technology, the evidence so far shows that you really cannot, it's not really recommended to use as a sole method, and it would be better with other type of methods instead of just the digital contact tracing technology. But there are many challenges for policymakers. I think in terms of the evidence, the main challenge is that we still are seeing that the majority of studies in public health measures are mathematical models. What does it mean? It means that the scientists are taking assumptions, and based on these assumptions, they are supporting the evidence on these areas. But you know, we still need a lot of observational studies, cohorts, and going forward to be able to identify how these public health measures actually work in real life. In the meantime, obviously, you all have to make decisions if you are a policymaker, and but this decision has to be really based on your context and your setting. And one of the things that we've identified through the literature is actually to understand that a combination of measures might be better placed to reduce the number of cases and deaths. Unfortunately, one thing that we are lacking at the moment, we're lacking evidence in a lot of areas, but especially in economic and social harms. And but as I mentioned before, this evidence is evolving very rapidly. So it's very important that we think about applicability on different settings. And in our end, in Cochrane, we'll keep what we call living systematic reviews that is very updated as new evidence becomes available. Thank you very much.
Thank you, Carla, particularly for highlighting the importance of looking at the evidence before making public health guidelines, and also weighing, the different measures and seeing which works better and what's more cost effective and efficient to implement. I'm going to hand over back now to Sanjeev and Matt to go on to the question and answer session, as we've come to the end of our presentations. And I think each of the panelists has given an overview, which together I think add up to quite a large body of information. And I'm sure the viewers have questions and doubts, which we can go to now.
All right, wonderful. Thank you, Dr. Swaminathan, and to all of our panelists for sharing your expertise today. So the first question, this is a live question from JP McMenamin. So what is the most optimistic projection for herd immunity with respect to the fraction of the population that needs to be exposed? And does the South African experience allow us to draw any conclusions about weather conditions and the likelihood of transmission?
Marion, would you like to take that?
Well, that's a tough one. Well, so initial estimates have been around 70%, but have come down a little bit with the observation that there is a certain component of cross-reactive immunity from pre-existing exposures. However, I would say that that we do not have real evidence to say it's significantly lower than, let's say, 60% at least. A big question that has been out there, of course, is there what is the role of prior immunity? I mean, what would this have looked like without any of these cross-reactive antibodies and T cells? But I don't think we can say anything significant there. I do think the example from South Africa and maybe also India is intriguing, in the sense that why does the shape of the disease pyramid seem to be different? And is there maybe a different immunity factor at play in your context? But I wouldn't dare to say anything more than that.
I agree with you, and I would add two things. One, that we shouldn't get complacent that some of these countries, the herd immunity is just going to happen, because let's remember these studies are in select populations in highly dense urban settlements. And even if you take studies in India, we know very well that the seroepidemiological studies, which have been done in the more rural districts, have shown seroprevalence rates of 1 to 3%. And this is true of many other countries. So I would caution everyone to not fall into this trap that we're already reaching herd immunity. We're nowhere near it. Globally, we know that 90% of the world's population is still susceptible. And wherever the virus encounters susceptible populations, it will go ahead and infect. And we should only talk about herd immunity in the context of vaccines, because otherwise the price that we're going to pay in terms of lives is going to be very high. Of course, the exact cutoff we don't know, as Marion said. What we know is that the higher the R0, or the transmissibility of a virus, the greater the percentage of the population that needs immunity. So for measles, you need more than 95% coverage with a vaccine and population having antibodies. So for this virus, because the R0 was between 2 and 4, we think you need about somewhere between 50 and 75 or 80%. But there are a lot of studies going on now looking at this question of immunity, T cell immunity versus humoral neutralizing antibodies, and also the duration of protection. So I think we're going to be learning a lot in the months to come. Matt?
Thank you. Over to you, Dr. Arora.
You're muted, Sanjeev.
I think since we're hearing about these issues of 40 to 50% people having antibody, etc., what is the latest understanding of what percentage of patients are actually asymptomatic? Because this would indicate that that number could be significantly higher. And certainly, Soumya, you talked about maybe differences between, let's say, India and the US, but what is the latest estimate of this number in the Northern Hemisphere, etc.? Do we have some data on that?
Maybe Anne can come in and then I can comment.
Okay.
So just related to also herd immunity, to think of the heterogeneity of populations, and South Africa is such a good example. We're such an unequal society that different people living in different ways in different communities, there's nothing so simple as herd immunity, I think, to consider. So I think we need to be much more nuanced in our understanding of what herd immunity or herd protection might be. In our study looking at the household transmission that I introduced, in fact, it was very unexpected. But of those people that we tested that were PCR positive, almost 90% of them were asymptomatic, did not seek care, did not go to any hospitals, and were not tested, were not picked up in any formal way in our case numbers. So I think it's unexpected how much asymptomatic transmission we're seeing in South Africa in our communities. Over.
May I add an observation from studies in our country? That's again the warning about interpreting outbreak studies, where we've had situations where we did screening of healthcare workers in an outbreak setting that all indicated they did not have any symptoms, but then when the test results came back and they were interviewed in more detail, they said, oh well, but I do have this and this symptom, I just didn't think that was COVID. So really getting at the heart of, is it asymptomatic or mildly symptomatic in our studies has been very difficult.
Is Dr. Butler still there?
I think he may have left. So
I don't see him.
Yeah.
So George, what's the proportion of asymptomatic? Of course, you have hardly any infection now in China, and you know it depends a lot on the testing strategies of countries, Sanjeev. So it's very hard to compare because the policies and strategies are different. Testing availability of diagnostic testing is different, and so in the majority of countries, at least earlier, you were only testing symptomatic people. But where the contact tracing is very good, you're probably going to pick up a larger number of asymptomatic infected people. George, want to add something to this?
Well, you know, because we, of course, especially in China, we introduced the containment, the lockdown in Wuhan. And in whole China, we don't have many antibody positive cases there at all. So, you know, we finished up our serology work recently, serological epidemiology. Like, you know, you have not less than 90,000 in 100 million population in Wuhan. So you see, it's a, you know, it's very, very small numbers with asymptomatic infections. Of course, it's still higher than what we reported. We finished up the data recently. We are still doing analysis. I think we will report this soon. Roughly, it's very similar to what you found in the other countries. Very similar, but not the same. Like, you know, every one positive case, you might have 5 or 6 asymptomatic cases in Wuhan. But in Beijing or any other countries, because it looks like, at least in China, the lockdown, the containment worked very well. You know, we didn't have any really good pace in the first wave in, you know, Beijing, somewhere, for example, the capital. You know, you only have some cases, very small numbers. So for the antibodies, I don't think we have any herd immunity in China at the moment. As for the numbers, I don't think we want to be a witch to predict anything, because we have no data, we have no experience for the coronavirus. This is the first, you know, pandemic or first epidemic for coronavirus. It's not the other 4, it's a sporadic cases. We don't know how the human immunity, you know, responds to any coronavirus. I think anything, any prediction, it's like you're doing something like a witch, you know, you just predict, you know, press your head, okay, here's the number, like Marion said, 70%, or she wants to get down to 60%. 60%. Maybe I'll say, okay, maybe, what about 50%? What about 90%? Not like measles, something like measles or any other virus, we already know the numbers. I think we have to be really careful about those numbers. We don't want to be a witch anyway. We want to be a scientist. Let's wait and see. Keep doing all this kind of panel discussion. We might be able to approach to the real fact. Thank you.
Back to Matt.
All right, thank you very much. The next question is from Sean Pin Fengcheng. And can you comment on the implications of case reports regarding reinfection on transmission?
So I can start and someone else can come in as well. So we have now a handful of case reports of reinfection. They are growing. I think there are reports coming in from many more countries now. And we're looking at this very actively. Of course, we have to put it in perspective. We've, just crossed 30 million cases, and we still have the reinfections reported in 2 digits. But what it does show is that reinfections are possible, they can occur, and there's probably a range of protective immunity that's developing after the first infection. But we also have to be careful. We have to look at the methodology of the studies. We know that RNA can persist for a long time. So if it's a PCR that's coming up positive again, then we have to be careful how we interpret that. And that's where we need the genetic sequence data as well to be very sure that the infection is truly a reinfection and not just the persistence of the original infection. So this is, of course, important. It has implications for protective immunity, for vaccines, and so on. And again, from the other coronaviruses, from SARS-1 and MERS, we know that the duration of protection is limited from 1 to 2 years. But here, in some instances, we've seen reinfections within 2 months, within 4 months. So I think it's an evolving field. We have to keep an eye on this. Marian or anyone else want to comment?
Yeah, indeed, to emphasize the importance of both doing the serology around the cases for the first and the second episodes and the sequencing. I do think there's now good evidence with sequencing from not even a handful of cases, but neither of them, including one that we have reported, has the full immunoassay part attached, because oftentimes people have had an illness episode, were tested, those samples were there, then recovered, went home, not tested for antibody development because that's not routine. So you don't know, even with the cases we've seen now, whether those first episodes were people that just didn't have a very strong immune response, because we see quite a range in immune responses in people with different degrees of severity of illness. So that could be very well what is happening in the first episode. And I do think we still need to understand a lot of that.
Okay. I think there are 2 questions from Africa, one from Peggy Chibuwe from Lusaka in Zambia, and one from Yagoba Kane from Dakar. One, of course, is a very sad question, is what advice would you give to a family that loses a mother to COVID-19 and have to care for infant left behind? And of course, the other one is limited. What do we anticipate is the impact on Africa for this pandemic, and how sort of best to control it? Over to you, Soumya.
So for the question on the infant, yeah, this is extremely sad and reminds us that we are seeing people in the prime of their life without pre-existing comorbidities also succumbing to this illness. So again, a reminder that this is not something that only affects the older population or people who have underlying illnesses, but also can be very severe in younger people. Now, for an infant who's lost a mother, we know that in these settings in Africa, large parts of Asia, it's very difficult. The child doesn't have now breast milk. Luckily, there's extended family support in these cultures. And so hopefully the child will find, it's important not just for the physical and the nutritional support, but it's really important for the bonding, the mental and cognitive development of this child. But I wouldn't think that there are any specific or special precautions. We know that congenital infection is extremely rare. It has not really been documented. And depending if the child were to have had congenital transmission or perinatal transmission, that the child would have presented with symptoms very soon after birth. So hopefully the child should be healthy and can be looked after by like any other healthy child. I think important to avoid stigma and discrimination in this case, because that's the last thing we want to add to the burden that this little baby already has. In terms of what's expected for Africa, again, I don't think we have a crystal ball. What it has been seen so far has raised a lot of questions about. People had predicted that there would be explosive outbreaks and that things would really get very bad in Africa. We haven't seen that happen till now, but we also know that this virus can continue with transmission at a level, in the community where it's not so obvious. And then when it reaches a certain level, it then becomes, there are many more people then falling ill and occupying the hospital beds and so on. So I think we have to be extremely watchful. We have to build the diagnostic and testing capacities, and we need to ensure that people continue to adhere to these public health measures. But as Anne pointed out, these are quite challenging in many of these environments. Anne, would you like to add anything to the perspective from Africa?
Yes, and I think that from our perspective, I think the economic hardships that are going to follow after the lockdowns and the restrictions that were in place are going to be felt for a very long time. And I think we may not have seen as much from the severity of the pandemic from a sickness point of view. And as you're rightly saying, that we still need to wait that out. But I do think we're going to feel the economic hardship in Africa.
Thank you for that, making that point extremely important. And I want to add also the impact on other diseases, because we have more or less seen disruptions in essential health services that have impacted TB, HIV, malaria, antenatal and maternal and child health care, immunization services. The survey that WHO did showed that 90% of countries that responded to the survey had said that there had been significant disruptions in these services, including non-communicable diseases, cancer, mental health, everything. And I think the impact of that disruption is also something that we haven't seen yet. And perhaps in the days and months to come, we will have to really, I think, strengthen these health systems to respond to these challenges. There's been dramatic reductions in TB case notification, for example, in many countries. And it's not true that TB suddenly disappeared. People have not been able to come for diagnosis and for continuing treatment. So a reminder again that health systems need to now learn to manage COVID and continue to provide services for all the other health conditions which have not gone away.
All right, well, thank you. To conclude, this is Matt. To conclude today's session, we'd like to thank all of our panelists today and also Dr. Soumya Swaminathan for helping us understand how COVID-19 is transmitted based on what the evidence is showing us. We also want to thank everyone on the network for attending this session today, this ECHO COVID-19 Global Learning Collaborative. And want to alert you that our next session, such session led by Dr. Swaminathan and an international panel of experts, is scheduled for Monday, November 2nd. And we will discuss at that time what we have learned about clinical management of COVID-19. And there will be a link in the chat box, so please go ahead and register for that session on November 2nd as well. It'll be the same time of day as this one. Many of you have also been joining us already for the ECHO COVID-19 Global Conversations. And I want to let you know that our next of those sessions is next Monday, September 21st, and there will be a link in the chat box for that as well. We will have an international team of expert panelists talking about cancer care in the time of COVID-19, a very vulnerable population during this pandemic. And then also in the chat box, please find the link to obtain your CME and CEU credit, and please complete your survey to provide us with feedback. And then also watch for email announcements and visit our website, which will be also posted in the chat box, the ECHO COVID-19 Global Conversations and Global Learning Collaborative website for any sessions, updates, and information. And as always, thank you again for your continued interest in Project ECHO's special programming on COVID-19. And we hope to see you all next Monday, the 21st. Thank you, everyone.
Thank you, and many thanks to all the panelists for their time, and to you, Matt and Sanjeev.
Thank you, Dr. Swaminathan.
Bye-bye.
Bye.
Bye-bye, everybody.
Bye.
George.